And among the themes that were discussed at this meeting and were included in one of the lectures I gave was that local relapse rates are falling, which of course is good news for women, and that is coinciding with an improvement in cure rate, not only as a result of radiotherapy, but as a result of various other improvements in early presentation, surgery, pathology, imaging. But clearly I was concentrating on the benefits that we could derive from radiotherapy. And we were discussing in particular the advances, the technical advances in radiotherapy and our ability to target the area within the breast that was at the highest risk of local recurrence with modern radiotherapy equipment, for which we rely, as we have always done, on collaboration with our surgeons to mark the area within the breast where the cancer used to be. So either with gold seeds, which show up on our X-ray machine imaging, or with titanium liga clips that surgeons already use routinely to mark their surgical sites, and that we can then image in real time inside the woman when she attends on a day-to-day basis for her radiotherapy. So that would be a technical advance, an example where a technical advance together with collaboration with surgeons can lead to clear benefits for women, whereby being able to image the tumour bed, as we call it, on a daily basis allows us to leave much narrower margins around the tumour and allows us to treat less normal tissue, which in turn leads to a lower level of complications. And that trend towards reducing the harmful effects of radiation is carried over in a series of trials that are testing particularly in low-risk women, or women who are perceived at low risk of local recurrence after breast conservation surgery, and increasingly other forms of systemic therapies, including endocrine therapy, whether we can reduce the amount of breast that's treated with radiation. And so traditionally, whereas we treat the whole breast after the surgeon has removed the lump, there are now randomized trials in which a number of countries are participating, where we compare whole breast radiotherapy, which is standard, against what we call partial breast radiotherapy, where the radiotherapy is restricted to the area where the lump used to be. And those randomized trials are largely still ongoing. The first results should be available in the next year or two. And I think the evidence would suggest that in a selected group of women that tend to be in the older age groups and with smaller tumours, that the radiotherapy can be restricted to a very small volume in the vicinity of the primary tumour, and that spares a lot of healthy tissue from the damaging effects of radiotherapy. And that partial breast radiotherapy can be given in as short as a single day in the operating theatre, or over a period of a few days post-operatively. And that last observation that highlights a compression of treatment time for radiotherapy was I also picked up in my talk. In the UK in particular, but also in Canada, for example, we've been interested in the biology of how breast cancer responds to radiotherapy, particularly the size of the daily doses that we call fractions. And whereas traditionally in radiation oncology, and entirely appropriately for example, head and neck cancer, lung cancer, and other forms of cancer, you can spare the healthy tissues relative to the cancer by giving lots of small doses, lots of small fractions in typically 2 gray, the gray being the unit of radiation dose. It seems that breast cancer is as sensitive to the individual dose of radiotherapy as the healthy tissues. And so if we give lots of small fractions, as we have done historically, we may be sparing the cancer as much as the healthy tissues. And so we and others have conducted a series of randomized controlled trials that have tested a smaller number of higher fractions, lowering the total dose over a shorter period of time. And so, for example, in the United Kingdom, we recently reported early results of a trial testing a single fraction given once a week for 5 weeks against a standard regimen that gives 5 small treatments every week for 5 weeks. And the early indications are that we can identify a schedule given as just 5 treatments that has the same level of late side effects as 25 fractions of small doses. And so that would lead to further randomized trials, large ones involving thousands of women, where we wish to test tumor control naturally. But I could foresee a time in the future, and it may not be so far ahead, where instead of giving 5 or 6 weeks of radiotherapy to women with breast cancer, to the whole breast, we are giving not only treatment confined more to the region of the highest risk of local relapse in the vicinity of the tumour bed, but also giving it in a much shorter treatment time, maybe as short as 5 days if we're giving external beam radiotherapy. The final area that I would pick out that is very much a theme for the future in radiation oncology, as it is in all branches of medicine, and certainly features largely in this conference in relation to systemic therapy of breast cancer, we wish to identify not only those women that are greatest need of radiotherapy, but those women that have got the most to gain from radiotherapy. And there are increasingly interesting research studies that are being reported whereby we can use biological markers of the tumour to actually identify subgroups of women that have got the most to gain from radiotherapy. So, for example, nice data from colleagues in Aarhus presented at this meeting, which show that particular subgroups of women, we refer to them in a form of jargon, ER positive, HER2 negative subgroups, luminal A, in other words, within the jargon, where radiotherapy appears to be preventing 9 out of 10 local relapses, which is an extraordinary sensitivity to radiation. And there will be other subgroups where clearly radiotherapy appears, if these data are confirmed, to be where the tumour cells seem to be more radiation resistant, as they appear to be to chemotherapy. So as in line with the rest of oncology, the sort of the biological information that's been accumulating over the last 10-20 years is now starting to enter the clinical space quite well. Women would always be interested in two aspects, as you well appreciate. They would want to say, well, look, do these advances improve my cure rate? And clearly, any treatment strategy in, say, for example, a woman that's higher than average risk, which tends to be the younger age group, I'd have to say, if we can target the radiation dose more accurately to the area of the breast which is at higher risk, and we can do so with narrower margins of healthy tissue surrounding it, then we would be able to actually assure that woman, well, yes, we think we can dose escalate safely and effectively. We will improve your chances of remaining free of cancer within your breast, and we would then be able to reassure her that we would also improve her chances of being cured of breast cancer overall. You know, in a woman, and it would only be typically an older woman, doesn't have to be old, just a few decades older, where we can say, look, your local relapse risk is already low after your operation, and if you're able to tolerate these anti-estrogen tablets. But so the priority here is we think we don't need to irradiate all your breast, and that's where the research is going, and as I mentioned. So on the one hand, in the low risk group of women, we're wanting to expose less of the breast to radiation. In the high-risk group of women, we're concentrating on safe ways, effective ways of increasing the dose to the region at highest risk. I don't think I'm the right person, the right expert to ask on proton therapy. Where proton therapy is concerned, the great benefit, as you will appreciate from your question, would be the physical dose distribution. And it certainly is impressive when you see that either in a CT scan or on a patient. And it may well be that in terms of the boost therapy in some women, that would act as a very, very useful and attractive supplement to the external beam therapy that we're giving at the moment. Whether that turns out to be cost effective would be a matter for research, but I would agree it's an interesting research question. I wouldn't like to hazard a prediction as to whether it would turn out to be cost effective, even in the setting of a wealthy country.